I'm Deb McGrath. I'm a nurse practitioner by training, and I'm the former director of health information technology for Health Federation of Philadelphia, which is a health center controlled network. We offer technical assistance around IT, EHRs, optimization, et cetera, for 33 health centers in the state of Pennsylvania, and I have a focus on cardiovascular health right now. I'm working a lot on SMBP, and I'm here because the health emergency is going away, so is telehealth. The sky is falling, so I'm trying to figure out how to get people to imaginatively think about telehealth as a tool that supports their other services and programming, and
Great.
how I can have that conversation.
Awesome. Anyone else want to share why they are here, who they are, what they want?
Hi, I'm Shannon McAllister. I'm the AVP for Population Health and Telemedicine. That might be enough of the why, but we really focused on care model redesign pre-pandemic to mesh population health and telemedicine, and coming out of the pandemic, a lot of those same reasons, but just really interested in what everyone else is doing.
Awesome. We're just sharing if anyone wants to share some info they want to get out of the session before we kick it off.
I don't have that much to share. I just didn't want you to think I was some weirdo in the back. So I'm Michelle Manahan. I'm the Assistant Medical Director for the Johns Hopkins Office of Telemedicine, and I'm here just because I think anytime we can transform, it's exciting, and I want to be part of that.
Love it. Anyone else want to share? Okay. Good exercise. Thanks, Faye. That was a good idea. Yeah, I need them. I had a waffle this morning, so. Hi, everyone. I'm Dan Weberg. I'm a ER and trauma nurse by background, and going to be your facilitator today. I love system change. I've been involved with the Matrix conference for a long time, so I'm going to be a moderator for our esteemed panel around new models of care related to behavioral health. And we have some great conversation. We want to hear questions from you, so we'll do a couple questions from the group and go out to you to ask questions as well. All the bios are on the side. I know it's a matrix sort of tradition not to read bios, so they're all on the session on the app. Face a hi from Vinaj Ventures, who used to be my boss when I was at Kaiser Permanente, and so we worked together, and is now a venture capitalist in the behavioral health, mental health space. Dr. Stephen Locke, who's a practicing psychologist, psychiatrist, and sorry, no disrespect, and is also involved with Harvard Medical School and a founder of a practice as well, and is big into telehealth and technology-enabled mental health care. And Commissioner Nelson Smith, the Virginia Commissioner for Behavioral Health, right? And developmental. So we have a very interesting. What is it? DBHDS. Oh yeah. Thank you for your help. Yeah. So they're going to provide very different perspectives, right? Technology, practice, and government, as well as different varying experiences across the health system. So let me just kick it off a little bit with sort of what ChatGPT said, because that's my new passion is ChatGPT. So I ChatGPT'd what the current state of behavioral health is in the United States. I won't go through the whole response, but it did say these 5 things are the main issues: access, stigma, fragmentation, insurance coverage, and COVID. Would you guys agree to that? Is that anything to add? As a theme?
Yes, access covers a lot.
Yeah, access covers everything, right? And then so I said, well, what are some statistics that actually kind of back that stuff up? So these are a little data. Remember, ChatGPT is 2021, I think it's trained through, at least right now. So 1 in 5 adults mention or have some sort of behavioral health issue. 28 beds, there's an average of 28 beds per 100,000 people in the United States from an inpatient behavioral health access point. Roughly 18% can say they cannot get care when they seek it out for behavioral health. Depending on the year, suicides either number 10, 12, 9 as the in the ratings of why people die in the United States. Overall, access was the major theme through all of it, that there's just not enough.
It's the number one cause for teenagers.
Yeah,
Number one
people,
cause
yeah.
for teenager. So is there anything in there you want to add, really, as far as sort of framing? So let's start with Faye. Sort of from your perspective, what is the current state of mental health in America?
Just to add, so 1 billion people are suffering in the world with the mental illness now. So the World Health Organization, from that standpoint. And if you look at it, it takes from the onset of a symptom to actually get the right diagnosis, care, treatment, 10 to 11 years. 10 to 11 years. Can you imagine that, right? If it's your child going through that incident, having to go through a wait list, so on average, that's the average. That's incredible. How can we disrupt that from that? And so that's what's been motivating me of like, how can we look at this big growing area of need and look at it? So from an investment side, and I'm from the investment and venture capital, you've actually, before like 2018, before like 500 million. That's on average on the venture capital. Now we're at 4 billion a year. So you've seen incredible growth in this area and recognizing the need for investment, innovation, emerging care models, kind of ways to disrupt. So it's been really interesting on that, and it was wonderful to be at Steve's panel too, and kind of, seeing where, what's emerging in this area. So I'm excited to talk about that and what care models, what things are persist. But to your point is, you could have the best things, but if people can't implement it, and the barriers and the culture and the training or the staff, how do we come over some of the barriers? But I'm excited to kind of share some of those as well.
Dr. Locke.
Yeah, I'm going to take a somewhat different perspective and talk about the employer's perspective. We used to talk about, at various stages of discussing health costs in the U.S., people used to use the example of the fact that 25% of the cost of a car is the healthcare costs of the people who build the car, and that it's actually more than the cost of the steel in the car. I don't know, that was data from 10 years ago. I'm not sure if it's any different now. It might be even worse. But to that point, when you ask employers about what the cost of healthcare is, the cost is not just the cost of either if they're using an insurance partnership and they're paying for insurance costs, or if they are self-insured, there are direct medical costs for their employees when they get sick. But if you look at productivity and including both presenteeism and absenteeism being people who go to work but they're underproductive because they have a headache or they're in pain or they're depressed, it turns out that the leading causes of lost productivity in the American workforce are mental disorders or things related to mental disorders, such as substance use disorders or pain or stress-related conditions such as headache. And so employers are increasingly interested, and this is why we've seen the growth of contracts with companies like Headspace Health or Ginger, Spring Health. There are a number of digital mental health companies. Faye probably could rattle them off. And these companies have been selling subscription model care to employers on a large scale in big contracts to provide those services in order to improve the mental health status of their employees. And the reason is that we, especially as we begin to bring our manufacturing back into the U.S., we need to be able to increase the productivity of our workforce.
Great. Commissioner Smith.
It's pretty interesting. I've been in this role for just over a year now. I started with our governor, Youngkin, and we just went through a total transformation, and the transformation is relative. Lots of studies that have been done year over year, so we just kind of collated those things. And But it was interesting to see a lot of the data that came out of what we're looking at, and one of those things was human beings, right? All the systems and things that we put in place, it requires humans to do those, right? So nationwide, there are less people. I forgot the number. We had McKinsey come in and help us with some of this. They have their healthcare incubation, or they have lots of data. At any rate, so nationwide, our children, our youth, they're graduating and they're getting into other things. And then also, and this is nationwide, we have people leaving healthcare at higher rates. Burnout, because of all these requirements, regulations, things that we put on top of them. So there's a lot of opportunities in that space. But our human beings, right? How do we get people excited about this? Because any amount of money that we put towards it, people are still leaving. I've had LCSWs or licensed clinicians tell me they're bartending now. And I was like, wow, I've heard this, it's anecdotal throughout the state of Virginia, but they get told thank you more. And they actually do make a little bit more. But again, the requirements that are put on people, burnout. So I would say human beings are central to all of these things.
Yeah, and when I was at Ascension, we were having trouble recruit sort of the unlicensed assistive personnel because they were working for Amazon because they got better benefits, better working hours, less poop and yelling and all the things that go along with healthcare work. And so we saw a lot of them move when an Amazon facility popped up. Most of our techs and things would go there. So there is a huge issue related to capital. And then I was just seeing today or yesterday, so it's match season. The physicians, med students are coming out into match, and I think it was 20% of ER matches are not matched this year for ER physicians. Yeah, it's huge.
Sorry, what did you say?
It said 550 emergency room,
Matches.
open spots.
Wow.
Yeah, so people are not choosing emergency medicine as a specialty, and that used to be a very popular one that was well-paying and hard to get into. So we're seeing shifts in what people are going at. So the way I'm going to run this is I'm going to ask a question primarily to one person, but everyone can chime in as they see fit. So I'm going to start with you, Commissioner Smith. How do we serve more people using evidence-based models with our existing workforce challenges, and how might we rethink some of those?
Sure. I'll just put my notes on the floor.
Here, I'll get it for you.
I don't need them. Thank you. This is the one we talked.
Yeah.
So
You
I'm
got
very
it.
excited about this. Virginia, I'd like to brag, we're leading the way, or at least I'd like to think so, on the crisis system of care, Crisis Now model. If you've not heard of it, you can look it up. We were able to fund and get passed through legislation the funding for 988. 988 is similar to 911. And it's a crisis line that people can dial. And I think this is a nationwide program. We're a little bit ahead because of funding, but through workforce. So it's a place to call, people to answer, and someone to respond, and a place to go. And so right now, I'll tell you our real-time data here in Virginia is we receive about 6,500 calls per month. Out of those calls, we're able to resolve 93% of those on the line, on the phone. And the average length of the phone call is 23 minutes. 23 minutes to save a life. And then out of those 93%, the remaining, we can launch the mobile crisis services. So you talk about like technology, it's just a phone call. Mm-hmm. And behind that is a data system that has a drop-down menu. We have to be culturally competent. We're taking all these things into consideration here. Geographically, Virginia is very different, by region. So, at any rate, so we launch a mobile crisis team to meet the Virginian where they are, whether it's in the street, whether it's in their home, but it's with dignity. It's not with blaring lights and all these things. Although sometimes law enforcement will still need to be involved, but the goal is to make that less and less. So you see, as this moves along the spectrum, someone responds. Of that, we're able to resolve over 70% of those in the field. And then somewhere to go. That's a place where they receive treatment, a Virginian, a human being. This is nationwide in America. Someone receives treatment. Instead of, you hear it all the time, how many hours, how many days people are sitting in an emergency room without treatment. Well, our model of care is not designed. We can talk about stigma and all these things, and our emergency rooms aren't set up for that, right? So we're creating these things called crisis receiving centers, 23 hours up to a few days for child, adolescent, and adults, where they can receive treatment right away, where law enforcement can drop off within 5 minutes and be back in their communities. So to me, it's very basic. We have that technology to do it right now, some cars and some phones and people to talk to, right? So I'm very, very excited about that. 988 is going to be I think the hope for nationwide.
Dr. Locke?
I have a question for you. After my session a little while ago, a physician came up to me and he said, we have encountered a problem when we use a standard questionnaire for screening for depression, the PHQ-9. We had a conflict about whether to ask question 9, which is a question about suicide risk. They decided, and I agree with their decision, that it would be unethical to avoid that question just because the lawyers say we don't want you holding the responsibility because you know that that person is having suicidal thoughts and you're not, it's the middle of the night and you don't have care available. So the question is, can a practice that is screening patients, which might happen any time of day if it's interactive online, if they identify somebody who they deem to be at risk, can they simply tell the person to call 988? And can that be a reasonable way of doing other than having to hire people 24/7 to man that phone line?
I mean, that's a great question. I'm not going to answer like, yeah, let's do that. It sounds like a great idea. And that's something that I could take back. I mean, the idea is that.
He's in another state, by the way.
Yeah, I was gonna say. Well, that's a good point. The lead in. You haven't heard about it. Probably it's not front and center. Although behavioral health care is front and center, you haven't heard about it. It's a nationwide program, and like for example, we may be very good at it here in Virginia, but if we go full scale marketing, which I can't wait to do. We did a soft launch in July. This July, we're going to go full-scale marketing. That's the SAMHSA's goal. And so I have to consider, like, if I go full-scale marketing in July and my neighbor states are not ready, is that going to pull in people into our system? You know, we've got to do it together. But 988 should be that. And it also is going to be more than people think. What we've designed it to do is those people that get resolved on the line, they get connected to appointments, follow on next day or week, I don't know how soon, don't quote me on that. But the idea is that they can, you often hear that people don't know where to go or what to do. I've been in the emergency rooms, nights and weekends. Healthcare shuts down for some reason on the weekend, which we have to fix that. But parents don't know what to do with their kids. So then this lets them know what to do. It connects them with that care.
Yeah.
So that, again, I'm very excited about it.
Yeah, well, and the existing practice is when you have an emergency in those clinics, they call 911 to have them go take them to the ER. I wonder if it's a similar sort of model. It's just a behavioral health emergency, yeah. So it could be, there could be existing practice in those clinics.
I think, to your point, Doctor, I think it will be.
Well, also, there are evidence-based tools, like, for example, the Columbia Suicide Severity Risk Assessment. There are standardized tools that can be used by people who don't have to have a PhD or an MD to determine the level of risk, and then that can feed into what the appropriate level of response is.
Yeah, we were talking about this earlier, is we were looking at our state. What do we have? We keep talking about all the things we don't have. Psychiatry, for example. We are so short. 68% of psychiatrists in this state don't take insurance. I mean, that gets into reimbursement. But what do we have? We have family practice. We got all these things. And so we have a program called VMAP here. You can look it up. How do we expand that and use and leverage the people that we have to wrap around them, to your point, sir, so they know how to use a basic screening tool. When a kid goes in to get a physical for soccer practice or to go to school, right? Or why aren't we doing those screenings off-ramps? So we're looking at innovative things like that here.
Faye?
I know you had your hand up. I just want to make sure.
No, I think I was just going to mention with that question 9, I ultimately think they got to the right decision of asking the question, but when you think back at that 6,500 calls, 93% of cases resolved, that positive question 9 is easy in primary care to like scream and say, oh no, like my day is just shot, but sometimes just a few follow-up questions to really clarify what they meant by answering that can really screen out a lot of people who are not truly actively suicidal.
Mm-hmm.
And I think things like VMAP and what they're doing in pediatric training of comfortable with mental health cases, an adult sort of supplemented program needs to happen. But again, it's another thing on primary care's lap, but that's.
Healthcare literacy in its basic, I mean, that's really what, when you hear we didn't know where to go or what to do, it's part of that. 75+% people who go to emergency room don't need inpatient care. They just didn't know where to go.
And ERs don't know how to deal with it.
Yeah.
As an ER nurse.
Yeah,
Yeah.
we've been seeing some interesting models. To your point, we do not have enough clinicians that are trained in this area, but now if we start looking at communities, so we've definitely seen it happening in schools, after school programs, community centers, churches, religious centers, and so and we've also been seeing different states start doing peer-to-peer reimbursement and coaching kind of models. We've seen the group therapies, and now we're kind of seeing kind of virtual automated kind of chat bot ones with kind of algorithm driven. So I think from this standpoint, it is going to take all of us. So we were talking earlier, it's not just the government coming in, it's not just the healthcare, it's all of us coming in together, because it's a big enough problem, and we need a sustainable solution from that.
Yeah, and we were talking beforehand too of we need technology to extend the people we have. So to give them superpowers to be able to impact things, not just throw more people at it, because they're not enough, and we're not going to train them very fast. And so, if you can do screenings or get those extra questions answered in a way that doesn't require, 55-minute visit, and you have that data when you can talk to them or they are able to be routed to you, then you can be faster, more efficient on things and sort of have a superpower to reach more with the people you have. So I think those are all the pieces of the care model. And I wonder who's going to be disrupted. I mean, Faye, do you know any disruptors in this space? I mean, you might. I mean, it seems like there's a lot of, which moves into the next question, which I'll go to is, it's in-person care being put into virtual spaces. It's not a true disruption, I think, of what technology could enable. So, what are you seeing out there from a disruptive standpoint?
So disruptive, I agree with you. It gives you some superpowers. So interesting from assessment, and is like now you can kind of assess people by snippets of their voice. They just talk a few sentences. Are they depressed? Are they bipolar? Are they going to a manic period? Saliva testing, breath testing, your behavior on your phone, right? So there's some really interesting models kind of in the assessment diagnosis area that are really trying to kind of, rather than a standard questionnaire that you're filling out in an office and at that time and that mood, really kind of looking at it more holistically. So we've been seeing that biomarkers from that, facial expressions, eye movement from them. So I think there's some really interesting things coming in kind of from the assessment and diagnosis, but also in the treatment. I think with how we've reimbursed, we have this standard protocol, even with our pharma, of they go try this treatment, then this treatment, then this treatment, right? But if it's not right for you, and if you look at the millions of people suffering, why are we putting the same treatment on this Joe who's 14-year-old from this state versus an 80-year-old from the, how are we looking at it? So we definitely see a lot more personalization, predictive, proactive ways, preferences too, on how that it can be more effective and more engaging from that standpoint. And we also found the power of people together, right? I think to your point, when people are in kind of peer groups, they have support on their journey. They don't feel alone. They have people that have that experience with them. We've seen some success on both adherence and really having them get better.
Yeah, and that peer group thing has been interesting. I'll get to into during COVID, we stood up a crisis line for nurses. And what we found is nurses didn't want to talk to EAP providers. They wanted to talk to people who knew where they were, had walked in their shoes. So that peer support nurse coach model has really took off. When we said just, you have access to these resources, I don't want to talk to just anybody. I want to start where people know me. And so I think that's an interesting model. I
wanted to add to that one because we know a company that's doing the peer support of clinicians supporting other clinicians, but there was a real concern about being anonymous, right? Kind of fear of practice and knowing peer. So they actually do voice anonymizing real time in these groups, right? So that you can't identify the person, person feels very comfortable in really kind of saying, but then also getting advice.
Yeah.
So this is where now you have kind of technology to help supplement, protect, and, kind of get the aid.
That's great. Dr. Locke.
Another disruptor is computerized adaptive technology. And what it is it's a way of interviewing that means that you can make an inference about the presence of a diagnostic condition or somebody's status, asking fewer questions. All the psychometric theory and principles involved in standardizing and validating psychometrics have been based on paper and pencil tests or interviews, and they mean that the questions have to be answered in a specific order, and you have to ask every question that's on the page. But in fact, a lot of those questions may be irrelevant or may be able to be avoidable. So we're all familiar with the fact that you can get a medical history questionnaire which tells you if you're female to skip all the questions about menstruation or other historical types of differences between genders. And what this does is if you are answering a question and you don't have symptoms of loss of interest or feeling down, depressed, or blue, you don't have to ask the other 7 questions on the PHQ-9. With 85% sensitivity, you can go on and ask other questions. And so we don't have a statistical model yet for how the statistics were developed for paper and pencil tests. We're still evolving how to be able to validate the use of these more efficient tests that enable you in 3 minutes to do an evaluation that might have otherwise taken 15 minutes. So that's going to be another big breakthrough.
Mm-hmm. Yeah. Mr. Smith, any ideas on not just translating the in-person to the virtual, but actually reusing the tools of virtual to deliver care?
Yeah, I mean, we had to adapt as a state here. I mean, COVID-19 really changed how we had to do business when it came to assessments and screening. But no, not a whole lot to add.
And I think it is that superpower piece, and how do you leverage new resources in a different way, just not take your visit you're doing in person and put it online. So then I'd like to open it up to the group to ask a question before we go to the next one I have. Does anyone have a question based on the conversation now they'd like to? Yeah.
I was going to ask, with some of these tools to get those quick answers and responses, the other piece that we love about our job is documentation. How is this data and information then transferred to the EMR? Because we have a system now we use that we can send screening tools, but then we need people to manually enter them into the EMR. So have you all seen or, any innovation there with transferring?
Yeah, so that's actually when I've spoke to thousands of companies now, and that's been a question where I'm saying it's like, how are you integrating with an electronic medical record? What is basically your API? And so we definitely see a lot more integration on those kind of components on that and like how they're working. When I was at Kaiser, we were working with Epic from that, and Epic has this way of their orchard of how they're really starting to integrate and looking at that from that standpoint. And I think that's going to be key, right? How can you make it as easy as possible and have our clinicians focus on kind of the top of their practice from that? And then your record. There's some interesting kind of startups, and as you kind of look at it, is if you can imagine in the future, so what would for the future you want to be, right? And I know with my electronic medical record, when I changed, health plans or providers, right? It's a pain in the butt. Right? Like, it's like, okay, give me the CD. And they're like, I don't have a CD reader, and I don't have this. And you're like, oh, so I imagine a future where we own our own data. We know what's, rather than this clinician, this specialist, this, when you're at this job or this health, and that we own our data, but then we are able to have control of our data, who has access to the data, but also monetize our data for research, for clinical studies, for being kind of applicable for that. So I imagine from our kind of privacy or security, but are also empowered for the kind of, that's what I hope to envision for the future. But as to your point, the integration and data layer, we definitely see some efforts. So when Dan and I were at Kaiser, we worked kind of with all the CIOs of 5 major systems of like, let's not argue about data definitions and APIs and where we're going. Let's standardize. And I think that, to your point, we're going to need to do that. Standardize our data, our process, our interactions, so that we have that movement.
And that's the only way Epic's going to grow, right? They have 65% of the market. The only way they can grow is go direct to consumer. So we'll text Judy Faulkner. Any other thoughts from the panel? Yeah.
I think the best example I can think of where you have the opportunity for greater efficiency in documentation is not necessarily a mental health application, but it is a good illustration, and that is informed consent forms. Informed consent is a process. The form really is just supposed to document that it took place. Most people don't understand what's on the form. Most people don't read the form. I've had a number of surgical procedures, like a hip replacement in the last year. I didn't even bother to read the form. I just went to the bottom of the form and signed it. And that happens more often than we'd like to admit. However, if we had an interactive program that walked the person through, showed them either videos or animations that give the person some ideas to what they're going into, then what you would end up with is, after they go through this whole informed consent process, there would be a document which indicated what they gave permission to, and that would be what you would keep in the medical record. And so the clinician wouldn't have to really do anything other than to ask the person if they have any other questions, or if there's anything they can clarify for them.
Right. We're also thinking, like, so we kind of joked about ChatGPT, but in that sense is we think that ChatGPT, voice automation, dictation, smart phrasing, predicting from that based on standardized cases will really help the documentation. When we were polling our kind of clinicians, Kaiser actually tried 3 EMRs before we tried Epic, right? And from that standpoint, and we had a lot of resistance due to documentation. And the exhaustion from that, the burnout, the addition, in the beginning, the patients hated it because all they saw was now the laptop. They didn't even see the doctor's face because they're like busy trying to type in the protocols. But we see that getting more automated from that standpoint too.
Nuance is trying to do ambient voice to just pick up in the room and chart what's said. And they're very early. I've met with them a lot. They're very, very early. Yeah. But there are technology. I mean, there's people trying to push into that space, and it's definitely not there. But there is potential opportunity.
How many people have had the experience of having a scribe in the office with them when they were with a clinician? Raise your hand if you've had a scribe. How do you feel about having the scribe there? Depends, huh?
It depends. It depends on how the scribe is being used. In the case where I had a scribe, and the scribe stood between me and the provider. And the provider talked to the scribe and not to me. So I think it takes a lot of education and training and thought process on the part of providers and staff as to what this looks like.
Comment. There's also Google Glass scribes. I forget the company, though. We saw them. Do you remember, Faye, what it was called?
Yeah.
Where the Google Glass would be there and the scribe would be in the background.
Speaking with my other hat as a clinician, I would say that the issue that I think rises to the fore with scribes all the time is there is teaching. We do learn to interact with our human patients. There is a personalization that we learn. And when we use scribes, I think it comes back to what everybody else has said. Education is lacking in terms of what the role is, and it's not just a, it's not just a flesh and blood speaker into, a transcription service. So it's an issue.
It's come and go and fad too, I think. We've had scribes, we stopped them. We automated scribes, we stopped that. And so it's been interesting. Any other questions from the audience? Yeah.
Thank you. My question is from the EMR standpoint. The early versions of EMR basically started as a database of clinical records and patient records, and now with all the technologies and APIs and chat GPTs and so many integration, the role of EMR is also evolving, and it is evolving really fast. And the traditional EMRs that are designed, they are not designed with this idea of capturing, various data into the platform. But nonetheless, for example, somebody mentioned documentation is a bigger issue, but what we have done is integrate ChatGPT to do the smarter phrasing. So that kind of stuff is going to help, remove the burden from the providers to do documentation. So what do you see the future of EMR, considering so many technologies coming at it, and maybe 5 years or 10 years from now, and because EMR essentially is the hub of everything?
I could talk about what we're doing here.
Yeah.
I think is important because, well, I can't get into like the long-term goal, but maybe. So when I took over about a year ago, our agency had no strategic plan whatsoever, which, you'd say, well, that's typical of state government, right? Well, that's not okay, though. So we created one, and we have 3 domains. There's 740 actions, 36 key results, 9 objectives. It's really cool. So one of those under modernization is we're building a data exchange, sorry. We're also building a data warehouse, data exchange, and we're starting with our public safety net, public system. And the idea is one patient, one record. To your point is the idea would be our community services. You have an individual that lands in this community, goes to a state hospital, goes back to a different community. You have to recreate this record, or when they are in crisis, you don't know what medications they're on. So, I mean, it's bad in so many areas. We all know that. So the idea is, the goal is by 2025, we're going to have a data exchange that allows a Virginian to land anywhere within our public system, and we'll be able to have access with their whole history and where they go. Now, where that goes after that, that's the magic sauce. So we're talking, what does it look like our consumers interact with DSS? They interact with DMAT, Department of Medicaid, right? And then private providers. So where can we go with this? And I'm excited about that because, again, maybe we get to the individual carrying their own record, but if we can do that on the front, and there's some other regulations to get through, but we are building the data exchange here, and I'm very, very excited about that.
There's some startups in that space too. There's one called Seekster, which allows people to basically import all of their data from any EMR into a single spot, and the patient owns it and can share it and distribute it as they need to. And so I think there's going to be disruption in that space.
We do have we do contract with third-party companies, and one does, when you talk about HIPAA, it's able to transport the data, or I'm not a tech person, but it makes it anonymous to some degree for the transport. It's really, really cool.
Yeah, the HL7 feeds, yeah. Okay, or Dr. Locke?
I think interoperability is a necessary but not a sufficient condition to address this problem. I think that the EMR needs to be the platform of greatest utility to clinicians because with the growing collection of data, especially patient-reported data coming from home, remote patient monitoring, the one thing that will crash the system and will increase burnout is if clinicians have to access data coming from a variety of different sources. And even if a data warehouse enables all this information to come in to the electronic record, it has to be organized in a way that is useful. So, for example, if it drives me crazy with my current EMR that I can't see a longitudinal graph that shows the changes in a particular measure over time. And I'm on the clinician advisory committee for this particular EMR, and we've been asking them for over a year now to be able to take even just vital signs, but more importantly, something like a critical measure for a psychiatrist or mental health professional like the PHQ-9, which is used to guide treatment, adjust dosages upwards or downwards or switch drugs if it's not effective. And simple things like that just can't, are not there yet. And so finding ways to not just make the data able to be captured from different sources, but to be able to put it into a useful form can turn the EMR into a very powerful tool for guiding patient care.
I just wanted to add to that too, is like start looking at the data. So now add genomics on it. Add now all kind of the data, whether you're wearing a Fitbit or Apple Watch. Add now all these kind of survey and assessments. Add your social determinants of health, because we also know where you live, and that zip code has such a determinant on, on your health. So now it becomes very interesting, but as a clinician too, we have to, the information overwhelm. We need to really have it be very smart, predictive, only alert as needed, triage, automate, protocol. So there's gonna be a lot that goes in there, or else it's garbage in, garbage out, right? It's just gonna be too overwhelming. You're not gonna use the exhaust of the data, so.
Great, thanks. So I'm going to move us to the next question. This one we'll start with Dr. Locke on. How should evidence-based interventions and models be changed with digital health tools? And at Kaiser we created something called Imagining Care Anywhere, which is this provocation of the future. And one of the things we provocated, is that a word, provoked, was this idea of, it was a Medicare patient who was having early dementia and was at home. And so one of the things we thought would be an interesting digital intervention would be tracking, how often did he move within that house? And then a voice that would remind him to take medications, but not a voice of a computer or Siri, but of his daughter. And so so simple solutions that could potentially, and again, this was, I think, 7 years ago or something we did this. So, but it was like, what if you could use technology in a way that actually allowed people to stay independent or do different things? So interested in your thoughts on how digital interventions might be evolving for behavioral and mental health.
Well, it's interesting, as you ask that question, ideas start flooding into my head that I had never thought about before, So for example, when you mentioned the digital voice of his daughter, I started realizing that although we think of deep fakes as a bad thing, a deep fake could also be your doctor, and someone has written the text of what your doctor is going to speak, and your doctor speaks to you over a video connection and gives you directions, or can actually interact with you and answer questions in an interactive format. So we can actually create virtual visits or virtual guidance with people who are familiar, whether it's a family member or whether it's a clinician or a nurse practitioner from a practice. So that's kind of one area. Well, I think I'll stop there.
Well, it's interesting because when you were saying that, one thing we were kind of testing is virtual reality. And how do you use virtual reality to prepare your patient, right? So you can have them, in a sense, experience, what's going to happen with a surgery, what do you expect, what's going to happen after, so they can understand and be aware of it. But you've also seen virtual reality overcoming phobias and doing safe immersion from that and reducing visits by half and being in a safe environment where they can control it. We've seen virtual reality on pain management. You're now playing a game in the North Pole, you're very cold, you're reducing, as someone that is very sensitive to anesthesia, I like some non-anesthesia medicated related options for pain management. So I think there's just some really interesting ways as we kind of look and kind of evolve and personalize and are proactive on those.
I just recently had a patient who needed to get a thyroid function test. She was very depressed, and I was getting a lot of pushback from her, and what it turned out was that she had a history of fainting when she had blood drawn, and she had really was a very aversive experience for her, so she didn't want to go get the blood test done. And I was able to coach her through what she could do to make it less likely that she would faint, like they should lay her flat on a gurney rather than having her sitting in a chair, just as a, but In the same time frame, I got contacted by a VR company that that actually has 140 different environments, one of which is a laboratory where people have to go, and it's a very realistic environment, so it's very immersive, and the patient with a VR headset can actually go and from their perspective see someone coming to draw blood from their arm, and using cognitive behavior therapy and other exposure tools in the realm of behavior therapy, they have a treatment program to help people get used to having blood drawn, and it's critically important for people who have cancer and who have to get infusion therapy, because people could skip their sessions because they're avoidant, and it could be it could determine whether they're going to live or die.
Mm-hmm. And it doesn't always have to be VR and AI and stuff. I mean, like you mentioned, the phone, just giving access to a place to use something you have on you all the time can be an intervention that's very effective. And I think even back when we were looking at emerging technology, there's a text-based, I think it's ePharmix was what it was called. I forget what it's called now, but it was just text-based interventions for blood pressure and diabetic management, and it had really good efficacy. And it was simple things like, hey, how are you feeling today? Did you take your blood sugar? Enter it in. Like simple things, and that led to interventions and decision making that it was low lift for people. So it doesn't always have to be sort of that futuristic kind of stuff. We'll take one more question from the audience, and then we'll do a wrap-up question for the panel. Anybody have anything burning? Yes, ma'am.
I have a question about, you talked about stigma. And one of the things that we run into a lot when you're thinking about health information exchange, for example, is people overreacting to behavioral health information being a part of a patient's chart, particularly when you have integrated services in primary care. And one of the HIEs that I've worked with for years, just if it said LSW or if it said psychiatrist on the signature, they would not accept that as data coming into the data center, because attorneys like to drive the risk to zero about inadvertently sharing stuff. So I'm wondering what we should be doing about that aspect of things when we're talking about EHR, we're talking about combined records. You know, where is the conversation around reducing stigma by saying, why do we have such a taboo against a behavioral health data and information?
You want to take that one from a HIE standpoint, or?
Well,
Or a regulatory standpoint.
Yeah, regulatory.
That's where I was going. I think my mind always goes to the policy. Well, I do love the VR, because I think about our IDDD community with people. At any rate, so
Yeah.
I don't typically get into like that. So, but the policy level stuff, I think about a lot. And we did talk about, so when you talk about the stigma equals risk management, risk avoidance, risk tolerance, litigation, all these other things. And so it was something we were talking about earlier, and then, you know, between psychiatrist and the attending physician in the emergency room, that's a nuance that a lot of people don't understand either, right? So, and that's based on risk. And so it's, you know, there was something, we tried to get something into a bill. I don't think it got traction this year, but, you know, how can we give our providers, and maybe it's not the right answer, but some sort of like qualified immunity, similar to law enforcement, you know, where people can feel more comfortable treating instead of more worried about litigation or you know. The idea was, it was a conversation based on who is allowed to do what and when. So a lot of providers, when you hear in the state of Virginia, you TDO someone. Who's allowed to do that? It's our Community Services Board. Should we extend that to someone else? Not necessarily EHR, but it's risk related. We're having conversations about it, and it all came back to these professionals. They go to school. Do we trust them? Right? Trust.
Yeah.
Competency. Right? So we've got a long way to go on that one. We talked about like a team approach, you know, all these other things, but it is risk at its fundamental like heart.
Yeah.
Are you going to get in trouble?
And each provider group and each profession has their own risk tolerance. It's not a team risk tolerance, it's not a system risk tolerance. It's like, primary care has this thing, nurses have this thing, psychiatrists have this, like they all have a different perspective of what that risk looks like. And so they're trying, passing that around and not having understanding and a clear definition of it, I think is also probably an issue.
I have a license.
Yeah, right.
Yeah, it's a complex one. Just interesting as you were saying it, I was learning from a fellow peer that it's just like, so if you're a pilot and you're going for mental health, you cannot fly, right? If that's in your record, you're not able to fly, right? Let the FAA rule, right? Like, so, I mean, you have rules like this, and they're like, well, who wants to ever admit? So I don't even know how many pilots are flying around with mental illness because there's none. Yeah, right. So
you can drink all you want as long as it's not within 24 hours of your flying. But God forbid you should be on a psychiatric medication.
I know, that's just making me feel better to take my 6 a.m. flight tomorrow. But anyway, but then then you start going, okay, then you have this kind of the policy side of it, right? The challenge, people in the safety field not feeling safe from their career. But then you start going from the individual side. We know culturally, right? People of color, like Asians, are one of the least likely to go to mental health, right? Like I'm trying to work and educate, so we're like, it's okay. Like my dad, both of my parents are doctors, right? And he's going in for emergency open heart surgery, right? And I had to put all his medications down. And it's going to be the day later. He's like, do not put my antidepressant on there. I'm going to go cold turkey before I go to my surgery tomorrow. I'm like, no. No, you're not going to do that. And he's like, no, I am. And he did. And I'm like, because he was too embarrassed to let the surgeon know that he was on an antidepressant. I'm like, crazy, right? It's crazy making from that. But I think what's been really interesting, like we've been kind of on a task force to try and reduce the stigma. Part of it is just talking about it. Part of it is the education of it, and that it is something you can overcome, right? Like for the Asian community, as we're trying to uncover it, we're like, why is it so hard? And what's happening is if like I'm a child and I admit I have mental illness, the whole family gets blamed. It's the parents, you didn't raise them right, now you caused an illness. And so it's not just me, it's the whole family stigma of it as well, right? You go to other areas of trust, not trusting. You go others of access, I'm being labeled as crazy. You go into other countries and they literally incarcerate people that are crazy, right? They separate them from society. So, I mean, it's just, it's very complex, very passionate about this, but we do need to reduce stigma. We need to say it's okay not to be okay from that. And I think we all say it, right? Like someone asks you, how are you doing today? Fine. But inside you're like, no, I'm not fine, right? Like so, I think with our Olympic stars saying I'm not well, with these influencers saying I'm not well, it's starting to reduce the stigma because there's a lot more reporting, more than ever before we've seen kind of incidents. So.
I've taught generations of medical students at Harvard Medical School about doctor-patient communication, and so I've given a great deal of thought to the whole issue of stigma and how to train new clinicians about understanding their own biases as well as trying to understand the patient perspective and the cultural issues, some of which I don't understand because I'm a white male. But I think that the pandemic has done more to benefit to address the problem of stigma than anything else, because no family has been left untouched by mental illness in the last couple of years. I defy anybody in this room to tell me that there's no one in their family who has been affected by mental illness within the last 2 or 3 years or earlier or previously in their lives. And so the more people that we know that we consider to be normal people who happen to have symptoms of depression or anxiety or other more serious mental illnesses, the more people we know like that, that I think is really that and disclosure. And I think the fact that some celebrities periodically disclose their own struggles with mental illness. I think that those, everything that can reduce the perception of shame associated with it, I think will help. But I think it's different when you're talking about patients versus providers. And the example that you used, I think, I know it really gets my hackles up because it makes me start feeling punitive, because I feel that a practice that does that should be disciplined, that it's poor care, and that if that were reported to the Board of Medicine or to whatever the regulatory board is, they ought to be warning that practice that they're going to have to go through an educational program.
It's not the practice, it's the health information exchange that is keeping each other from knowing about this particular patient.
Well,
Behavioral health.
if it's in Virginia, this guy ought to do something about it.
If I invite you to come to my state, I'm not going to say it out loud. Come to my state and learn what not to do.
Well, I think the professional organization that you belong to ought to take this up with the insurance commissioner or the Department of Public Health.
Yeah, it's challenging. It's just super challenging. But I'm hoping that some digital tools and patient-generated information might help with this stigma piece. Because if I'm self-reporting it in a way that's pretty safe or feels safe, maybe it will just reduce that stigma. And I'm gonna just put one more point on this. When are we gonna start offering mental health services as a standard order for patients who have been through horrible trauma, who have been through, and not some religious person coming into their room and making them feel actually bad that they're not praying about this, because that's what I've just experienced. But I mean, really, really wrapping around, you know, I have a friend with Parkinson's, no mental health services. One person through a terrible cardiac situation, no mental health services. And you need to do that.
You make it part of primary care, preventative care, and not reactive
Just-
care.
right,
It's
it
like the
shouldn't
last
be
bucket.
It just should be
Yeah.
a matter of course.
Yep.
You've been through this, here's your treatment plan, and this is part of it.
The
One-
integrated behavioral health. you're saying?
Yeah, I was going to say one practical solution is that when electronic medical records enable you to order a psychological test or scale as easily as you can order a hematocrit, then it will contribute to destigmatizing it because it'll look like just another evaluative tool.
Yeah. So we have 3 minutes in happy hour, okay? Water or other beverage of your choice. So I want to just go through and wrap us up. So sort of one big nugget, our path forward. So we talked about a lot of opportunities. What's that one next step that we have to take from your perspective to move towards our desired future that we talked about today? And anyone can start that off.
Well, seeing as how we've just gone through this whole transformational kind of planning process, one of the things that the approach that we took is we always start from a systemic kind of issue, like one big thing, or it's a knee jerk, and let's do this. Legislators push this. We took an approach of the human, put I'm going to say a patient, they're not patients, a Virginian in the middle of this journey. And what does it look like? So we often say, and I'm all about technology, but low cost, high impact are things like peer support, peer services. Matter of fact, we have Year of the Peer here in Virginia, especially for behavioral health care. So the idea is that, I don't know, it doesn't matter where you are in any business, instead of trying to solve for what the customer wants, why not understand the customer and see what they need, like from their perspective. So that's what we did, right, for the state, is to, what does it mean for Mr. or Mrs. or whatever it is, and what does it look like for the journey? And that's how we're approaching it. And we surveyed the entire state. We actually put out stakeholder working groups from every interest group, you name it. So we got customer feedback. And we're creating a system designed to make an impact based on what the need is and not what the next whiz bang, and I don't mean in a bad way, but it's behavioral health care is interesting, right? And we need to listen to our consumers and design a system for what their need is, because it's unique and it's different. And every region of this state has a different culture and a different need. So it needs to be fitting of that. And that's what we've done here.
Great.
I think the most important thing is to take whatever steps are necessary to ensure that every electronic medical record has decision support tools for helping primary care doctors to manage patients with comorbid behavioral disorders. 16% of the index reasons for why somebody goes to see a primary care doctor is a mental disorder. And so it's more common than other conditions that we might think of for why people would go to a doctor. And those doctors need to be provided with the tools that they need to be able to provide that treatment, because there aren't enough, people won't follow through if they refer them out. And even if they do refer them out, there's the ability to find a psychiatrist or a therapist who can provide that care is very limited.
Definitely agree with all the points. You were taking my points. So the one I wanted, no, the one from, so I wanted to add to that is whatever we can do to prevent. If you look at it, more than half the mental illness starts when they're a teenager. So if we could just start looking at kind of our systems and in really kind of wellness, prevention, predictive, proactive, giving the tools to our communities, our families, our parents, our teachers, you know, our primary care physicians from that, so that we can kind of stem it. Because we be able to respond to the chronic mental illness at suicidal, you know, it's costly, it's dramatic, it's sad, it's heartbreaking, right? But can we really go upstream from that? And when you look at our health system, we are meant for sick care, right? Like, so we're gonna, I mean, that kind of looks at like, how do we kind of transform? There, you know, like I was kind of looking at the history books, and in China, way back when, they actually paid for wellness. So you were incented on wellness. Like, you've got to flip the whole model back, right? And it's value-based care. It's where, you know, where we're going from that standpoint. Now apply that to behavioral mental health.
Yeah. Where California, I think, is suing TikTok now, or investigating TikTok for its its impact on mental health and teens, and so yet to become. So with that, we'll wrap up. Thank you. So let's give a round of applause to the panel.